Hi, I'm Beth Stivers. I'm the Director of Education at the Epilepsy Foundation of Kentuckiana. Our agency is located in Louisville, but we do serve the majority of Kentucky, minus just a few of the northern Kentucky areas because Cincinnati covers those. And we also serve a few counties in southern Indiana. But our job basically is to support people with epilepsy as well as educate. And my job is to go around the state and train people and talk to them about epilepsy and seizures so that more people are aware. So we train teachers, we train school nurses, I train EMS workers, police officers, pretty much anybody that will listen to me for about an hour about seizures and epilepsy. So hopefully after today you will have learned a little bit more about seizures and epilepsy. The one thing I always like to add before I do a training with school nurses and teachers and school personnel is oftentimes school personnel are the first people to recognize seizure activity for children in the classroom or on the bus or in the lunchroom, because you all are with the kids more oftentimes than the parents are. So once you're trained, a lot of times the more subtle seizure types that a lot of people aren't aware of are things that you will notice and be able to inform the parents that maybe they need to have the child evaluated. So I'm going to move forward and do the presentation. So the presentation, seizure training for school personnel, we are going to talk about the different seizure types and how you recognize those. We're also going to talk about the possible impact those seizures have on students. A lot of times epilepsy, the seizures are obviously a huge factor in a person's life, but the issues people have with epilepsy goes beyond the seizures. Usually people have the seizures and then other issues do become more of a complication. So we'll talk about that a little bit. We're going to learn the appropriate first aid for the seizure types that require first aid. We are going to learn how to recognize when a seizure is actually a medical emergency, and then how to provide the social and academic support for a student that's had a seizure in the classroom, or again on the bus or the lunchroom, or just basically while under the care of school personnel. So let's just talk a little bit about what is a seizure. A seizure is the brief temporary disturbance of the electrical activity in the brain. And basically our brains function and they allow our bodies to function by sending electrical messages to various parts of the body to allow for different things to happen. So everything our bodies do, everything we think or hear or smell or see is something our brain is allowing to happen by sending these electrical signals. So for example, if a person were to have a seizure, the type where they fall to the floor and convulse, you're going to see their muscles shaking. You're going to see their rhythmic motion. And that is because basically for that particular seizure type, the brain is sending messages to every single part of the body all at once. And so that would also include the muscles. And so what might look very scary in terms of seeing a person convulse is actually the body's doing exactly what the brain's telling it to do. It's just the brain is sending a miscommunication in the form of a seizure and allowing this to happen. So if I wanted to move my arm, my brain would send a message to my arm to allow my arm muscles to contract. And then the brain would then release that, stop sending that message, and I can now relax my arm. So during a seizure, the brain is sending this information in kind of a pulsing way. It's sending message after message going from the brain down the spinal cord out to the body. And so the person's muscles are going to keep having this jerking movement and contracting until the seizure ends. And at that point, once the seizure ends and the brain stops sending these messages, you'll then see the body relax. So a lot of times I like to tell people, and I also like to remind myself, I've worked with the foundation now for 11 years, and when I see a person have a seizure, especially a convulsive seizure, a lot of times my first instinct, even though I have worked with a lot of different people that have seizures, I have assisted a lot of people when they're having seizures, I do panic a little bit, and it's hard not to do. It's just kind of something, you see something, it looks a little bit scary. But I remind myself, for a person that has epilepsy, they're going to have seizures, and you're going to see this behavior depending on what their seizure type is. So just remind yourself, it's just a matter of the brain sending a miscommunication to the body. So this is just a brief temporary disturbance. So it'll come on and then it'll go away, and different seizure types last longer than others, and we'll talk about those here in a minute. But it can alter many things. It can alter the person's movement. It can alter their sensation they might feel. It can alter the behavior they're exhibiting, as well as their awareness. So what is epilepsy? Epilepsy is a chronic neurological disorder that's characterized by a person having a tendency to have recurring neurological seizures. So epilepsy is can also be referred to as a seizure disorder. A lot of times I'll hear people call and say, I don't have epilepsy, I have a seizure disorder. If in fact the person is having neurologically based seizures, they do have epilepsy. And a lot of physicians will not use the term epilepsy because of the negative stigma that people have associated with epilepsy. So they will say seizure disorder because a lot of times people will more readily accept the diagnosis of a seizure disorder than they will epilepsy. So if you hear those terms, they're the same thing if in fact the seizures are neurologically based. There are over 40 different types of seizures. And I don't know them all, so we're going to talk today about the most common ones that are readily recognizable after you have been trained to recognize them. So epilepsy, just some facts, it's a lot more common than you might think. About 2.9 million Americans are currently living with epilepsy, and about 315,000 students across the United States. More than 45,000 new cases are diagnosed annually in children, and about 1 in 26 people will be diagnosed with epilepsy at some point in their lifetime. 1 in 10 people will have a single seizure, and in fact any one of us could have a seizure at any point in our life because we all have what is known as a seizure threshold. And so sometimes things can cause a person's seizure threshold to drop. Sometimes maybe a blow to the head or a metabolic disturbance, a blood sugar issue, that kind of thing can cause a person to have a single seizure and then not ever have another one again. But any one of us could have one at any point in time in our life. Epilepsy is more common than cerebral palsy, Parkinson's disease, and multiple sclerosis combined. So it affects a lot of people. And here are some things that I like to say. I'm not trying to insult anyone's intelligence, but I do work with people that I have to dispel a lot of myths, and you would think in this day and age that people wouldn't believe these things about epilepsy. But in fact, I do have to share with people that some of these things are not true. The first one here, most seizures are not medical emergencies. I think when we watch TV and the medical shows and we see someone have a seizure, you look on those shows and most often they're going to have all these doctors rushing to the person in the bed, oh my gosh, they're having a seizure. And when in fact, most seizures are not going to be medical emergencies. Most seizures, and we'll talk about the timing that we worry about a seizure being too long, but we don't want to panic when a person has a seizure, and we don't want to automatically assume that they need to go to the hospital. We have people that have multiple seizures a week, multiple seizures a month, multiple seizures a day, and if they went to the hospital every time they had a seizure, they would not have enough money to do anything because they would be paying medical bills constantly. Students may not be aware of the fact they're having a seizure or remember what happened after the seizure's over. Epilepsy is not contagious. Believe it or not, there are people that think they can catch epilepsy by being around someone that has epilepsy. It's not a form of mental illness. It is a medical condition. It is a brain disease. It is not a mental condition. But however, if I told you that when I have a seizure, I might say things, I might talk, I might be walking around appearing to be awake, but actually be out of my consciousness, be altered, that might make people think that it is more of a mental condition than it would be a medical issue. I also have a client that I work with that her particular seizure stems from the part of her brain that stores the memory of images. And for her particular seizure, she sees her grandmother standing next to her, and her grandmother had passed away years ago. And so I'm sure if I was standing here today and I said my grandmother's standing next to me and you didn't see it, I'm sure you would probably think maybe I did have a mental condition, but in fact that is her particular seizure. So seizure can be a lot of different things. It's not one size fits all. Many people could have the same seizure type and experience different things during their seizure. Students almost never die or have brain damage because of a seizure or during a seizure. However, I will say that while if the appropriate first aid is given, if the rescue medications are given, if what they have, we would recommend that students have a seizure action plan. And the seizure action plan would detail for that particular student the steps A through Z, what to do when they have a seizure. If that action plan is followed, if their seizure is stopped before it lasts longer than the period that the doctor says it should stop, and we'll talk about that here a little bit in a minute, then they're probably going to be just fine. However, if a person is left, if they're not receiving the proper first aid, if they're alone, when the seizure happens, unfortunately we do experience loss. We have lost clients that we work with due to seizures, and it's very unfortunate. But I would like to say you need to rest assured and you have the plan from the doctor the seizure action plan, and that will be what you need to do to make sure that that child is safe and that everything will be fine. A person cannot swallow his or her tongue while having a seizure. That used to be, they would say, find a wallet, grab, use your fingers, unfortunately, hold the person's tongue down so they don't swallow it. You can't swallow your tongue. Even if you're awake, you can't swallow your tongue, and just because you have a seizure doesn't mean your tongue is spontaneously going to be swallowed. I think the problem is where this came from was if you're on your back face up during a convulsive seizure, you can't, the tongue can fall back and block the airway. It's not necessarily, you're not going to have the tongue go down the throat, but if the airway is blocked, then the person obviously isn't going to be getting oxygen. So when we talk about first aid, we will put the person on their side that's having a convulsive seizure, which allows the tongue to fall in a position that does not block the airway. So we'll talk about first aid here shortly, but if I had a nickel for every time I heard somebody say they needed to find a spoon to put in someone's mouth when they were having a seizure, I would have a lot more money than I do. And in fact, it can be very dangerous to do that. So common causes of epilepsy. For 70% of people that have epilepsy, the cause is not known. They have a seizure, they go to the hospital, they have tests run, images, scans, MRIs, CAT scans, and they cannot find on the imaging anything that's pointing to why they are having these seizures. For the other 30%, though, there are common causes that can be pointed to. First of all, brain trauma, any kind of brain injury, and that can even be something that, a lot of people don't even consider a concussion as something serious, but it is serious, and that can, in fact, cause a person to develop epilepsy. Brain lesions, scars on the brain, tumors. We have clients that we've worked with that did not have epilepsy, and then suddenly they started having seizures, and then in fact they found out they had a brain tumor, and that was what was causing it. Poisoning, any kind of poisoning, lead poisoning, infections of the brain, meningitis, encephalitis. One of the individuals that I have worked with for many years, she was in 8th grade and she was an honor student, had never had a seizure in her life. Unfortunately, she contracted encephalitis, and because of that now has such a terrible form of epilepsy with so many different seizure types that she will live with her parents forever. And it's very unfortunate, but we do see that happening with meningitis and encephalitis. Brain injury at birth, and any kind of abnormal brain development. So basically anything that damages the brain, anything that grows within the brain to move the neural pathways, that kind of thing can cause a person to develop epilepsy. And just so you know, there are, a person can have one seizure type and a person can have multiple seizure types. And obviously, epilepsy is a spectrum disorder, so if they have one seizure type, they're probably going to be a little bit less affected in their life than they would if they had multiple seizure types. The different seizure types could include, there's two main groupings. There's generalized seizures, which involve the whole brain. When the whole brain's involved, there's always going to be loss of consciousness. The common types that you're going to see in the classroom setting are going to be generalized tonic-clonic, also known as grand mal seizures, and also absence seizures, which are known as petit mal seizures. I'll talk about a couple more here in a little bit, but just the main two are going to be those. Symptoms can include convulsions, staring, falling, and spasms. The other type of seizure our grouping of seizures are partial seizures. They are also known as focal seizures. So if you hear that terminology, that's where that is coming from. But like the name implies, it involves just part of the brain. And depending on where the activity is happening when the person's seizure happens is going to be what their body does, what they experience, or what you see happen to them during the seizure. The two main types that you will notice are going to be simple partial and then also complex partial. Again, the symptoms are going to relate to the part of the brain that's affected. So we'll talk about generalized seizures. We'll start with absence seizures. And with absence seizures, there's going to be, basically the person's going to be acting on, maybe they're working on something, maybe they're reading, maybe they're talking, and suddenly they're just going to pause and stop. They're going to have a very absent look on their face, a very dazed, blank stare. Their eyes may roll back in their head, but it would be like I'm standing here talking to you and then I'm back with you and I pick right back up like nothing ever happened. And for a student that has this type of seizure, they literally could have hundreds a day if they're not properly diagnosed, if their medication's not working for them. And so you imagine in the classroom for this 1 to 10 second time period that the seizure lasts, that's a lot of coursework missed. That's a lot of instructions missed. So a lot of kiddos that have this type of seizure, they are going to have some catching up. They're going to need some tutoring potentially. They're going to need to be getting that information that they lost during the seizures. A lot of times, unfortunately, it is it's confused with daydreaming, ADD, lack of attention. We've unfortunately had families that have called and had felt terrible when they had been punishing their child for not paying attention, and in fact, they found out the child was having seizures. So we do know that teachers a lot of times are the first ones to notice this because they're looking around at the classroom, they're talking to students, and they happen to notice this happening. But that's absence. Generalized tonic-clonic are the stereotypical seizure that most of us think about when we hear the word seizure. There's going to be a sudden hoarse cry as the diaphragm contracts. Again, the brain is sending a message to every part of the body all at once. They're going to have a sudden cry as the diaphragm contracts and forces air over the vocal cords. The person is then going to lose consciousness and fall. If they're sitting in a chair, they may slump over, but if they're standing up, they're going to fall. They're going to have a stiffening of the arms and legs, and that's the tonic phase, followed by the rhythmic jerking or the clonic phase. So that's where we get tonic-clonic. There will be shallow breathing. A lot of times drooling may occur. Again, the brain is sending a message to every part of the body all at once, and that includes the salivary glands. So what you might see some frothy saliva being produced, which might look kind of scary. Another thing that can scare people is that people do often bite their tongue when the seizure comes on. And so if you see blood coming out with that saliva, it can be very alarming, but just remind yourself they probably bit their tongue or bit their cheek, and that's what that is. There may be possible loss of bowel or bladder control. The skin, lips, and nails may turn kind of a dusky blue color. That doesn't mean they're not getting enough oxygen, as long as the seizure ends on its own within the 1 to 3. Typically, we say we want the seizure to stop within 5 minutes. But for a student, they're going to have a seizure action plan, and it's going to say in that seizure action plan when the physician wants either rescue medications to be administered or 911 to be called. The person may when they're coming out of the seizure, they may vomit. So again, when we talk about first aid here in a minute, getting them on their side is important to keep them from aspirating on that. They typically last 1 to 3 minutes. And if you are helping the person with the seizure, I promise you that 1 to 3 minutes may feel like an eternity to you. It usually does to me. So keep in mind that it's very important when we talk about timing the seizure, that you have maybe a stopwatch or something available, because it can feel a lot longer than it actually is. After the seizure is over, that's referred to as the post-ictal phase. They're going to have a period of confusion. It may take time for them to find their words. They may look at you kind of confused for a little bit, have a headache, tiredness, soreness, speech difficulty, but eventually the person will come around. They may be very tired for a period of time, and that post-ictal phase can last for some people longer than others. Again, in the seizure action plan, we're going to want it to be as detailed as possible, so hopefully we can get, whoever's doing the interviewing with the parents and getting the information from the doctor, hopefully we can get that information to also include about how long to expect the post-ictal phase to last for that person. So I'm going to go back real quick, and I'm going to talk about a couple other different types of generalized seizures you might see. There's one called tonic, which basically the person is going to stand up like a tree trunk and fall over. There's one called atonic, which the person could be walking along and they're going to lose muscle tone and kind of like a rag doll, just fall onto the floor. Those seizures can happen over and over again as well. We're going to treat those seizures. We're going to want to know with the seizure action plan what to do for those types of seizures. But if you notice a student that's falling a lot, that's stiffening up and falling over a lot, that would definitely be something you want to talk to their parents about, to make sure they're aware of it, because it could be a seizure disorder, and that's what's causing the falls. So first aid, there's no first aid for the other seizure types. They happen so fast, especially absence seizures. Usually the person doesn't have time to fall because it's just a brief period of time. But if for example, for the tonic seizures or the atonic seizures, and the person falls, the first aid that's usually going to be given is going to be whatever, you know, a lot of those people end up going and having stitches and band-aids and that kind of thing from the injuries from falling. But the first aid for the generalized tonic-clonic or grand mal seizures, we want to stay calm and track the time. And for that child, we're going to want to have the seizure action plan readily available. And I usually say, what if you are a teacher in the classroom and you know you have a student that has epilepsy, familiarize yourself with the seizure action plan before a seizure actually happens. So that way, when the seizure happens, you're not scrambling, trying to find paper and reading it. You're able to kind of, maybe you can look at it, but be familiar with it so you know how to act and quickly. But stay calm, track the time. And a lot of times I like to say, most of us carry our cell phones in our pockets, or we have, if you don't have a stopwatch for this kid, we want to maybe just pull your cell phone out, go ahead and hit the stopwatch app. I find that's so much easier when timing a seizure than looking back and forth to a clock, because in the moment you might forget where the minute hand was and you might let it go a little bit too long, or it might not be an emergency yet and you thought it's been an emergency. So just to be sure, get the stopwatch. If you were in the store and you saw someone fall and have a seizure, it's not necessarily going to be a medical emergency, because if a person's diagnosed with epilepsy, it's not always a medical emergency. So if you happen to see someone, just check to see if they're wearing a medical alert bracelet or necklace, and if they are, then you can wait the 5 minutes before you call EMS, because most of the time the seizure is going to end on its own, and rather than tying up the EMS workers with a seizure that's probably not a medical emergency, we can just wait it out for a little bit. Protect the person or the student from possible hazards. Rather than picking a person up and moving them, if at all possible, we would want to maybe push chairs and tables and desks out of the way and leave them where they are. Now, if it's an extreme situation, obviously you would want to do what you had to do if the person falls in the road or whatnot. But for the most part, we want to just move things out of the way and keep the person where they are. We don't want them to, if you were to restrain a person, which we never want to do, it could break a bone, tear a muscle, or you could also get hurt. We want to turn the person on their side. That allows any kind of fluid to drain out of the side of the mouth rather than down the windpipe, and also that allows the tongue to fall into a position that does not block the airway. Obviously, we want to cushion the head. It can be anything from a balled up sweatshirt to your hands. Just hold the person's head and keep it from hitting the floor. And then after the seizure's over, we want to remain with the student until their awareness is regained, until they're fully aware of their surroundings. And again, it might take a little bit of time for that to happen. And we want to ask simple questions. And I avoid yes or no questions just because it's easy for a person to mumble yes or no, even if they're kind of out of it. My favorite question is I ask people, do you know who I am? And if they are not quite back with me yet, I can kind of see in their eyes, and they'll kind of, obviously they don't know who I am quite yet, but when they've come back around, they quickly know where I am. Also, where are you? Do you know where you are? What year is it? That kind of thing. We want to provide any emotional support. A lot of times when a person's had a seizure, they come out of the seizure and they're very emotional. A lot of people are very embarrassed about having their seizures, and we can imagine a student, especially as they get older in the school system, teenagers, it can be devastating for their friends to see this happen to them. So we want to make sure we provide that support. Oftentimes, if the teacher acts like it's not as big of a deal and kind of goes and does the first aid and doesn't panic, then that kind of sets the stage for the rest of the class. We want to document any seizure activity. That's important because for a person that has seizures, that's the way they figure out how to tweak medications and treatment options, is the doctor will ask when they go in for their appointment, how many seizures have you had since your last appointment? So if you can document that as best your ability, if it's absence seizures, just hatch marks or whatever you need to do, just ask the parent what they need you to do and make sure that the information is recorded so that the parent can share that with the physician. And just remember, you all are part of the treatment team. Their child, this person's child, is with you a lot of times more often than they're with their parents, so you are part of what's relaying that information to make sure the doctor is getting accurate information. So things you never ever want to do for a person that's having a tonic-clonic seizure. We never want to put anything in their mouth during a seizure unless, of course, it is in the seizure action plan that they have an oral rescue medication. And a rescue medication is different from just a everyday pill that they take to control their seizures, and those would be maintenance medications. A rescue medication would be something that dissolves very quickly, something that they are not going to aspirate on or swallow. So you would know in the seizure action plan if this medication has been prescribed, and you would be trained on how to give it. But anything else should not be put in a person's mouth. And another thing you want to remember is after they're coming out of the seizure, we don't want to give them any food or drink. And obviously not during the seizure, but when they come out of the seizure, we want to avoid food and drink, because if in fact they went into another seizure, which can happen, and they had fluid or food in their mouth, that could cause a problem. And then we don't want to hold a person down or restrain them, because we don't want to hurt them. We don't break a bone or tear a muscle. So special situations, if a person has a convulsive seizure, and it says in a wheelchair, but it can be a chair as well. If a person's seated and they have a tonic-clonic seizure, it's not necessary to move them to the floor unless unless this person kind of has a pattern where it's known they're going to need diastat or the rescue medication that's given rectally. But if they're seated and if they don't have, they usually come out of their seizures before the 5-minute mark or whatever the time is in their seizure action plan that indicates that they need a rescue medication, then we would leave them seated in the office. A lot of times I just kind of stand and I kind of have somebody get on either side of the chair, and then I try to just make sure that their airway is clear and they're not hitting their arms or legs on the side of the chair. But for a wheelchair, we want to obviously make sure that it's in a locked position, and then we want to just protect and support the head and pad their limbs if you notice that they're hitting the chair. But we leave people in their chair all the time, and I think a lot of people think, oh, I've got to get them to the floor, but unless it's pretty clear they're going to need rescue medications administered, then we leave them in the chair. If it were to happen in water, one thing about water, if a person has a seizure in the water, we can't be sure if before the seizure happened they didn't aspirate any water. So we always want to, and also we don't want to drag them out of the water and hurt them in the process. If at all possible, the best thing to do is to hold the person above the water until the seizure ends and then get them out of the water. If you're not a strong swimmer, like I'm not necessarily a strong swimmer, and if somebody had a seizure in the water next to me, I would get them to the side of the pool and pray that we're both safe, but obviously you want to keep you both from drowning. But just make sure the person's head is above water. If the person's not breathing after removed from the water, go ahead and begin rescue breathing. But we always want to go to the hospital. The person always needs to go to the hospital and get checked out after having a seizure in water. That can even include a bathtub, just to make sure they didn't aspirate anything, because later that could cause pneumonia or breathing issues. On a school bus, we want to pull the bus over and stop. We want to place the student on their side. If they're sitting in the chair, if you want to just lean them over into the seat with their face out from the back of the seat, or if they're halfway to the floor, you can lay them in the aisle. Follow the first aid or whatever the seizure action plan says to do for that student, and then when they regain consciousness, again, you can continue to the destination or follow whatever school policy or whatever the seizure action plan says. And this is where seizure action plan, and I say that all the time, but this is where the seizure action plan is very, very important, because different parents want different things. Some parent may want them to meet the bus and take the kids. Some parents may want EMS to come. So for each child, it's going to be very different, or it could be very different. So make sure you know what the wishes are. And I say also have an addendum. The seizure action planning forms that we offer provide a lot of information for the teachers, for school personnel. However, there are situations that you could possibly think of that, on the school bus or on a field trip or that kind of thing, that if it's not included on that paperwork, go ahead and have an addendum made up. Work with the family, work with the school nurse, work with the principal to have all the information you could possibly think of ahead of time in case a seizure were to occur, just to make sure that that child is safe. So when do we consider a seizure, especially a generalized seizure, a medical emergency? Again, the seizure action plan is always going to trump any of the information that I'm sharing here, because for that child, that is when the seizure is a medical emergency. For some kids, it's 1 minute. For some, it could be 3. For some, it could be 5. It just depends on the likelihood of that child's seizures not stopping on their own. And a lot of times people will have kind of a pattern to their seizures. So it's kind of like if they've had many seizures that didn't stop on their own, a parent or the teachers will know that that's that child's pattern. But for first-time seizures, we always want to go get checked out. The child should always be transported. It could be something, it could be a metabolic disturbance. It could be blood sugar related. It could be something dangerous like that. It could be that they have a toxin in their body, or it could be they have a brain tumor. So we always want to get checked out. For a convulsive seizure that lasts longer than 5 minutes, or again, whatever the seizure action plan says, for repeated seizures without a person regaining consciousness, we would consider that a medical emergency. However, if the person has a seizure, they regain consciousness, they are talking to you, they're back with you, and then suddenly they go into another seizure, unless the seizure action plan says that that is a medical emergency, we would just repeat first aid. Now, if it happened again and again, obviously we would go ahead and either administer the rescue medication per the seizure action plan or call 911. If more seizures happen than usual, again, a person a lot of times has kind of a pattern to their seizures, and if you spend time around that person, you'll learn that pattern. And if it seems more than usual, or if the type suddenly changes, then they're probably going to want to go to the hospital and get checked out. If the person's injured, or if they have diabetes, or is pregnant, if you're pregnant, a person always needs to go to the hospital. If the seizure occurs in water, if normal breathing does not resume, obviously if they are not breathing, then we would give CPR until the ambulance came. And then if the parents request that the person be transported every time, which most parents are not going to do because it's costly, then we would not call 911. But if the parent requests it, it's in the seizure action plan, follow the seizure action plan. That is kind of the Bible for that child to follow for their seizure or seizures. So those are the generalized seizures that are the most commonly recognized. Now we'll talk about partial seizures or focal seizures. I'm going to refer to them as partial in this presentation, but if you hear the term focal, it's one and the same. The first type of partial seizure is going to be simple partial seizure. Full awareness is going to be maintained for the person that's having a simple partial seizure, and again, it can be many, many different things. If we think about our brains and how many different, if we thought of our brain as a map, and we thought of this little spot, or this little spot, or this little spot, it could be a different thing that a person experiences or feels based on any little spot in the brain. So we could see many, many different types of behaviors or the feelings that person experiences during their seizure. So it could be a rhythmic movement. It could be something a person's arm just starts doing this. Typically they last 10 to 90 seconds. It could be twitching of the arms, legs, or face, and it's something that the person may not even realize they have epilepsy. A lot of people are probably living with simple partial seizures and don't recognize it as a seizure. It's not necessarily something that many people are educated about. They could have some kind of sensory symptoms, maybe a tingling, a weakness, sound. I worked with a man who hears music when he has his seizures. Smells. I work with a person who smells fried chicken when she has her seizure. I also work with a woman who smells burning hair. So it could be anything. A taste. I have a client who says it feels like her tongue's being touched to a battery, that kind of zap feeling. A feeling of upset stomach, nauseous feeling, visual distortions. Again, any of those could be a seizure, and it would be something the person kind of experiences over time. They notice it happening and go to the doctor because they notice other people maybe aren't smelling the same thing they are at the same time. Psychic symptoms, deja vu, hallucinations, like the client that I work with who sees her grandmother. I mean, that definitely is a hallucination, but it is a seizure that's causing that. A feeling of fear, anxiety, just a feeling the person can't explain. These, again, usually last less than a minute, 10 to 90 seconds. A lot of times it's confused with acting out, mystical experiences, psychosomatic illness, or a mental illness. What I talk about is one that's very misunderstood. A lot of times people can't understand that it's a seizure because it looks more like a behavior issue in some people. But this complex partial seizure, basically it starts when the person is going to lose, they'll be acting normally, and then suddenly they're going to go into a period of impaired awareness. Their eyes are going to be open. They may be up and walking around, but they're going to be having some different they're going to be exhibiting different behaviors related to the seizure in the brain that's going to cause the person to either they're going to have an inability to respond. A lot of times they may be with their own mother and not recognize their mother. You may be able to, you may call their name or say something to them and they'll just keep going. They're going to then have a blank day stare. They're going to have what are known as automatisms, which are the automatic movements or automatic behaviors that their body exhibits based on where the seizure is happening in the brain. Some of those movements may be kind of a weird, like a blinking that's kind of an odd blinking, or a lip smacking, like a they may wring their hands, they may pick at their own clothes, they may walk up to other people and pick at their clothes. It could be literally anything depending on where it's happening in the brain, but it's going to be kind of a repeat until the seizure ends. They're going to have clumsy or disoriented movements. They may go over and they may pick something up. They may then also run up and down a hallway cursing and screaming. Again, depending on where that seizure is happening is going to be what you see them do during the seizure. It often lasts 1 to 3 minutes. Usually it ends on its own before the 3-minute mark, followed by tiredness, headache, nausea. The problem with this seizure type is if the brain while their awareness is impaired, the brain still wants to protect the body from danger, like a reflex. So if I touch a hot stove, I don't have to think about that. My hand will automatically jerk back if my hand's being burned. So much like that, if a person is approached suddenly by something, the brain may perceive that as a threat, and the person may respond violently by kicking or screaming or pushing. Now, it's oftentimes confused with drunkenness, drug abuse. You can imagine, especially with the opioid situation, aggressive behavior, and we've actually had clients who have been arrested while having the seizure type. One particular, she is probably about this tall. She has some cognitive impairments from a stroke she had a few years ago, and she does have complex partial seizures, and she does become violent if cornered or grabbed during her seizures. Problem for her was one night she was watching a movie in her apartment and then went into a seizure, and she got up and walked out of her apartment, and her apartment had an indoor hallway, and she was wandering up and down the hall, wringing her hands, looking confused, and an elderly neighbor happened to see her and didn't recognize what she was doing as seizure activity and walked up to her and grabbed her and asked if she was okay, to which our client, who is normally one of the most passive human beings ever, responded by popping her in the face. And unfortunately, while that technically could be considered assault, she didn't have any control over it. She had no awareness of doing it, and unfortunately she was arrested and taken to jail, and when she told the police officer she had a seizure, he had not heard of this, and so therefore she was locked up and had a long legal battle ahead of her to get the charges dropped. And that's something we hear all too often. We've heard nationally people getting tased while having a seizure because the police say stop and the person keeps going. The one thing I do want to train police officers is I do like to mention, if the person's acting normally and then suddenly they have this behavior that's different from usual, and then they come out of it and they seem groggy, but obviously drugs and alcohol aren't going to wear off between 1 and 3 minutes. So try to think about, is this a seizure, before you automatically assume something about a person. And I've heard a lot of people that I work with, teachers, they have a hard time thinking of this as a seizure instead of behavior, because if it is aggressive or if it is violent, it's a problem in the classroom. So we just want to make sure when the person's having this, that if they do become aggressive, that that's something that's expected and we avoid that. So first aid, there's no first aid for partial seizure, or for simple partial seizures, because the person remains aware. But for complex partial, we want to stay calm. We want to reassure others. Tell the classroom they're having a seizure. Usually if we're at work, if I'm at work and one of the clients that I'm working with is having complex partial seizure, I'll just let them wander around the office and keep them safe, make sure they don't wander outside or get into traffic. Want to track the time, and again, I'll pull my cell phone out and I'll hit the stopwatch, because it's the easiest, most reliable way to make sure that I'm keeping an eye on the 5-minute mark. We want to check for, if you are in the store and you happen to see someone having what you suspected to be a complex partial seizure, I just kind of give it a look and see if I see a medic alert bracelet or necklace. I'm not going to go up and grab them clearly. But if I see something that resembles that, I'm going to wait 5 minutes before I call 911. If not, go ahead and call 911. And in the meantime, don't restrain the person. Gently guide them away from hazards. Some people you can calmly walk up to and maybe touch their arm and guide them away. Other people, if you take a step towards them, you're going to see them start to become, aggressive or fearful of you. Just take a step back. Maybe I call it hurting. Maybe walk a large circle slowly around them. Talk calmly to them. Stay with the person until they're fully alert and aware. And then once the seizure ends, and this says 5 minutes or beyond what is routine, I typically just stick with the 5-minute mark if I don't know that person. Again, the seizure action plan would come in handy here. So if the seizure action plan says longer than 5 minutes, you follow that because that's what the doctor said. However, if it's just in public, I'm going to go ahead and call after 5 minutes if I don't know that person. But again, that's one thing that's nice about having the seizure action plan is you know exactly what to do for that person. The reason we don't want a seizure to last beyond 5 minutes is because the likelihood of a seizure going into what we call status epilepticus at that point is greater, and that is a continuous state of seizure activity or prolonged seizures that occur in series. So there is some question as to, like absent seizures that just keep happening over and over and over again. I mean, I would consider that status, but someone else may not. But again, that's one reason the rescue medication is available, because we don't want someone having a seizure that lasts longer than 5 minutes. Past the 5-minute mark, that's when we start to worry about brain damage and death occurring. So again, following the seizure action plan, giving rescue medications as dictated per the seizure action plan is very important. This is a true medical emergency, and it's most common in the very young and very old. However, it can happen to anybody, and it can happen without warning. So just have the seizure action plan, be aware, have the rescue medications as close to the person as you can in case a seizure happens. Whatever the school policy is, we just want to make sure that they get the medicine when they need to if the seizure doesn't stop on its own. The rescue medications that are available, we do have several. I know there's the nasal Versed that's right now FDA approved for 18 and up for rescue medications. We also have the Klonopin wafer that is oral rescue medication that is given in some instances, but the gold standard since about 1997 has been diazepam rectal gel, also known as Diastat, and it is a rectal Valium that's given to stop a seizure. For some people, it can be kind of an embarrassing situation, so I do like to say for a student, especially as they get older, we want to make sure that the privacy can be protected. I oftentimes recommend for a person that has, to the parents, I talk to them when they are diagnosed with epilepsy and they're worrying about how they're going to handle the situation at school. I say have a backpack, have something available, has a seizure action plan in it, maybe a change of clothes if the person is prone to losing bladder control, and also a sheet or something that can be held up so somebody can hold that up and block the view if in fact the students can't leave the classroom before the medication needs to be given. If the students can leave the classroom and allow that to happen, that would be even more ideal. But we want to make sure that privacy is given because it can be very embarrassing in that situation. And it says state and school district regulations often govern the use in schools. However, Kentucky was the first state to require that Diastat be given on school property and to have somebody on site at all times to give Diastat to a student in need. So we go to conferences nationally, and there are states that you would think, I can't believe you all have passed this yet. But we do know that there are still states that are fighting to try to make this law. And it's very important to think about, especially rural Kentucky, and how far and few between hospitals can be when we get out into the rural areas, and also how long it can take to get from the EMS to the school, then to the hospital. A lot of times that could be 30 minutes, that could be a long time, and not every ambulance has a paramedic on it, and paramedics are the ones that can give the IV medications that stop seizures. And so if there's not a paramedic on that ambulance, then that person could have a seizure until they get to the hospital, and that by that point it could mean a difference of living at home with their parents the rest of their life. It could be going to college or not going to college, or it could be losing their life. So we are really happy that students are able to get the rescue medication they need when they're in schools in Kentucky. So I'm going to go over a few more things. One of the things that we notice for people with epilepsy, a lot of times they can have triggers. A lot of the common triggers are the ones I'm going to discuss, but I do like to say if you have a student performing a task in the classroom and they have a seizure and then they do it again another day, kind of mark that down. That could be a possible trigger. Talk to the parents, maybe work out something to accommodate that, change it up a little bit, because sometimes you discover triggers as you go through life. And again, these are the common ones, but I have heard any number. One of the people I work with says if she eats pork, she will have a seizure. So it can seem kind of off the wall to you, but I would listen to it and just avoid and have it written in the seizure action plan if there are known triggers, what those are. But flashing lights and hyperventilation, any kind of flashing lights, strobe lights, it could be in a movie, it could be on a video game, it could be just as simple as driving down the road and the light flickering through the trees. Those can all be any kind of things that could trigger a person. Hyperventilation is also another one. But other things are missed or late medication. Clearly, if a person's not taking their medicine, they're not going to have the seizure control they should be having. Or if they're late, and some people, they have to take that medicine right on the nose. Other people have a little bit more flexibility, but I would say if they say the medication needs to be given at 10 o'clock, get the medication to them at 10 o'clock. Stress and anxiety can cause seizures, and that is even in children. Lack of sleep or fatigue, hormonal changes. A lot of times with puberty, you will see a change in seizure activity or the onset of seizures. Also for women, when they get pregnant, they can start having seizures or going through menopause. And for girls, anytime during the monthly cycle can be a trigger for seizures. Illness, alcohol or drug use, drug interactions, and that can be even over-the-counter medications or prescribed medications. Overheating, overexertion, poor diet, missed meals, anything that stresses the body can cause a person to have a seizure. A lot of times the overheating thing is important. A lot of people that have this situation may have a cooling vest or something they wear in the summer months to prevent them from having seizures. The treatment options that are available, one of the things is going to be medications, usually the first option, or any combination of medications. Usually a lot of people we work with maybe take 4 or 5 different medications to control their seizures. Once they find that seizure control, maybe about 50% of people will be seizure free barring any of the triggers. 30% will have a marked reduction in seizure activity, and then there's about 20% of people that don't respond to any kind of medicine or treatment that's available right now. There's lots of research going on. Hopefully one day we will find a cure for epilepsy, but in the meantime there's the other option would be surgery, and they used to wait about 20 years before evaluating a person for surgery, but we do notice now they're starting to look at that process at the onset of diagnosis rather than waiting for 20 years and that person's quality of life suffering in the meantime. If a person does not gain seizure control with medication, they might not be a candidate for surgery. There's other options that are available to help control. One of those things is the ketogenic diet. I know that a lot of people are doing the ketogenic diet for weight loss right now, but it was something that was found in the 70s to help with seizure control. It's based on finding that burning fat for fuel rather than burning glucose for fuel has some kind of anti-seizure effect in some people. It's used primarily to treat severe childhood epilepsy. However, obviously with people doing it for weight loss, I think anybody could try it, but it would need to be done under the guidance of a physician. So it's kind of a medicine diet for a person with epilepsy. Somebody might try it and find that they have more seizures. So you want to make sure if a child has epilepsy that there's not just something that they do off the wall without talking to the doctor about it. But the diet includes very, very high fat content, low sugar, no sugar, low carbohydrate, and moderate protein. And it requires a very strong commitment. So if you have a child in the classroom or you're working with a kiddo that is on the ketogenic diet, no cheating, they can't sneak candy, they can't have a cupcake. And if that's the case, we want to talk to the parent. If there's a birthday party or something going on or a classroom party, let's the parent, if they can provide something for the child to eat that's not going to be, or you as the teacher, I know that we oftentimes have to do that, make sure that we have something there that the kid's allowed to have. And again, it's a medical treatment diet. Another thing you might see is called the vagus nerve stimulator or the vagal nerve stimulator, either way. And it's a pacemaker-like device that's implanted under the left chest wall. And usually if you look about right here, you'll see the scar for it. It's being implanted in children and adults. And it basically sends an intermittent pulse of electricity. It has a lead that wraps around the vagus nerve in the left side of the neck, and it sends an intermittent pulse that's set by the doctor based on how the therapy and how the person responds to it to go off every so often. And so we're not 100% sure how this thing works, but it's one of those things I kind of look at it as maybe keeping the highway. So the vagus nerve takes information from the body to the brain, and if that vagus nerve kind of gets the messages jumbled up, if you will, I know this is a very, very scientific explanation, it may cause a traffic jam and cause a seizure. So if we have the vagus nerve stimulator sending an intermittent pulse to the vagus nerve, it kind of keeps that information free and clear, maybe keeps that message from messing up and causing the brain to have a seizure. The cool thing about it is while it has its regular intermittent pulses that it goes off by itself, if the person does feel a seizure coming on, or you see them start to have a seizure, there's a magnet that accompanies the device that you can take the magnet, find the device by feeling it, take the magnet 1/1000 across the device, and then it will set it off in a minute's time. A therapeutic type dose will be sent, so it's just a little bit higher voltage will hit the vagus nerve, and a lot of times it can cause the seizure to not start if it's gotten in time, or it can reduce the amount of time a person has a seizure. So that can be used once per minute until, I would say, the 5-minute mark, or whatever the seizure action plan says. But you have to wait the full minute, because if you activate the device before it goes off, before the therapeutic dose goes off, then you're basically just resetting it over and over. So it's not going to hurt the person to set it off, but the only hurt you're doing if you use the magnet before the 1-minute mark is up is basically resetting it, and they're not getting any therapy from it. So just quickly, I'm going to talk about the impact that epilepsy has on the student. Seizures may cause short-term memory problems. After a seizure, coursework may have to be retaught. Sometimes kids have to have tutoring. Seizure activity without obvious symptoms can still affect learning. And the medications, a lot of times the medications can cause problems that are just as bad as the seizures: drowsiness, inattention, concentration difficulties. I once talked to a parent who had her daughter took 2 medications to control her seizures. She was a young child, maybe 6 or 7. The mom had the pills in her hand, was heading out the door to get the kid to school without thinking. Instead of giving the pills to the daughter, she just popped it in her mouth and swallowed it, and she was in bed for 2 days. So we think about the children coming to school on 2 medications, 3 medications, maybe 4 or 5, how they are soldiering through. It's unbelievable to me. And so I do oftentimes have to remind myself, for a person that's having epilepsy, a lot of times the life with epilepsy, aside from the seizures, are often a struggle in and of themselves. A lot of times people with epilepsy, students with epilepsy, suffer from low self-esteem. They may kind of want to take themselves away from the limelight a little bit. They don't want their friends to see them have a seizure. They don't want anybody to know. Some kids don't care. Some kids will, I have epilepsy, I don't care. But then there are the other kids that are scared. They don't want to be bullied. They don't want to be embarrassed, that kind of thing. And imagine having a bowel movement if you had a seizure at school and that happening to you in front of all your classmates. I mean, that would be humiliating. I mean, I wouldn't want it to happen to me at work, let alone in front of a bunch of children. School difficulties a lot of times may not be epilepsy related. They might need some counseling to work through other issues as well. The things that you need to do to support a student with epilepsy: we want to stay calm during the episode. You're setting the stage for the students to react to the seizure. To be supportive, have a copy of the seizure action plan, be familiar with it before the seizure occurs. Discuss the seizure action plan in the student's IEP meetings if they have an IEP. Know the child's medications and possible side effects. Now, I know you're not going to know every single medication a child's on, but if you have a list and you know if there's something written in the plan, watch for severe bruising, watch for that kind of thing. Whatever you are instructed to look for, just try to understand that you're helping this child with maybe medication tweaks or things like that. Encourage positive peer interaction. We also have a program that we do called Take Charge of the Facts, or for elementary students, Take Charge of the Storm Junior, that the Epilepsy Foundation staff will come to the school and talk to the kids and help explain to them what epilepsy is and what seizures are. And a lot of times we notice if that presentation is given, if a child has a seizure at the school, it does help the kids be more accepting. And a lot of times letting the kids know what's going on, taking the fear out of it by explaining what it is, and also giving them a way to maybe help their classmate will help them be a little bit less scared and maybe cause them to not be as bullying or whatnot. We want to avoid overprotection if at all possible. We don't want to follow the kid around and wrap them in bubble wrap. We want to try to make sure they have as rich of an experience as they can. We want to encourage independence so that they can have self-esteem. A lot of times though, I know it's scary, you worry about somebody falling and getting hurt, but you've got to try to just make sure you keep an eye on them and give them as much. There's a fine line you have to walk sometimes. Include the student in as many activities as possible. Communicate with the parents about the seizure activity, behavior, learning problems, anything like that, to make sure that everybody's working together for the best possible outcome for this kid. Now, this section I'm not going to go over. I know you all have your bullying training. You all do have bully training for Kentucky. So just be aware. Obviously, any child that's different has something different about them, anybody's really open for bullying in the school setting. So just keep in mind, keep an eye out for it. If you see it, make sure it stops. If you notice that the child is being picked on because of epilepsy, maybe think about scheduling a training for the students to help them understand. Maybe have myself come and do a training with the kids. I'd be happy to do that. Here's my contact information. Again, I'm Beth Stivers, Director of Education at the Epilepsy Foundation. You can contact me if you have any questions, if you have any students in the classroom whose families may not be aware of us. We do have services we can provide. We have a social worker on staff. Let me know if you need to contact me, and I appreciate your time, and thank you so much for sitting in on the training.